Hi, good evening, everybody. I am Donna Boynton. I'm Public Relations and Community Benefits Specialist here at Milford Regional Medical Center. Tonight we have with us Dr. Jeffrey Steinberg. Dr. Steinberg's specialty is urology, and his practice is located on Asylum Street, urology specialist of Milford. Dr. Steinberg's a graduate of Temple University Medical School, and he's completed internship and residency in surgery at Beth Israel Hospital in Boston and a urology residency at Harvard Medical School. Dr. Steinberg has been at the forefront of a lot of technological advancements in his field, and he's played a key role in bringing some of that here to Milford Regional, which he'll talk about tonight. Dr. Steinberg.
And thanks for coming out tonight. The weather's a lot better tonight than it was this morning. I was a little doubtful driving in this morning as it was kind of a monsoon. But yeah, as Donna said, I'd like to thank the hospital for hosting this series of community education lectures. So I've been in urology for about 25 years. I'm from Philadelphia originally, and Eagles Pats, November 17th. I'm not betting though, because the Eagles have not done well recently. But I grew up in Philly, and then I trained up here in Boston at the BI and the Brigham. And I've been around Massachusetts for most of my career, with a couple forays into Connecticut and Chicago. But urology is my true love of a specialty. And we were talking earlier to say, well, why did you go into urology of all things? And I tell some people, well, I just checked off the last choice on the page when they sent the thing around. But no, I really went into urology because it's a surgical specialty. A lot of it is not just life or death situations like I'm going to talk about tonight, urologic cancers, but a lot of it is quality of life situations, like how do we help men and women who have incontinence or erectile dysfunction or other problems with the urinary tract or the reproductive system. How do we help couples have children who are having difficulty having children? So it's a nice combination of both treating really severe illness, but also helping people with quality of life issues and really being able to bond with patients and understand their issues and being able to both have an office practice and a surgical practice in the operating room. So I feel very fortunate to have been able to be a urologist and to form very close relationships with my patients and help them through as they progress along during their treatment. So what I thought we'd talk about, because technology is moving so quickly in medicine, is some 21st century methods of detecting urologic cancers. So the old days of finding things on physical examination is pretty rare these days. We have so many sophisticated imaging techniques and laboratory techniques to find cancer in its earliest stages, because that's when they're most curable. And all of these technologies are now available here at Milford Regional. So I wanted to talk a little bit about this, and I'd be happy to answer questions as they come up, because there's just been an explosion in terms of early detection of cancers. Women were way ahead of us with way ahead of men with the annual mammograms that have been going on for decades now. And we've encouraged men to have their prostates checked. And you know what, to tell you the truth, you can't really tell much about the prostate by doing a digital rectal exam. We still do it, but now there's all sorts of blood tests and genetic tests and MRI scans, and I'll talk a little bit about that. So it's really taken a quantum leap in terms of hopefully finding these things early and then improving the ultimate outcome after we find the disease. So just to put this in a little bit of context, breast cancer is the most common cancer in women with about 230,000 cases. Prostate is the most common cancer in men at 233,000 cases. So they're about even. And then the other thing I'm going to focus on tonight is bladder cancer, which in men is the fourth most common cancer. And in women, actually is pretty low. It's not even on the list of the top 7 or 8 here. And it may be because of lifestyle, it may be because of smoking, and it may have something to do with genetics, that bladder cancer doesn't really make the top of the list in women. And then if you go down here, this is estimated deaths due to a particular cancer. Men more often, even though they have a lot of prostate cancer, they don't always die of prostate cancer, and that's because we're finding things early and when they're treatable. But lung cancer in both men and women are the most common malignancies. And in the old days when everybody smoked or had secondhand smoke, yeah, that was a huge risk factor for both genders. But now, unfortunately, lung cancer is still the most common cancer, even though we have all these smoking cessation programs and awareness, et cetera. Unfortunately, there are still genetic causes and other toxic exposures which may cause lung cancer. And still, it's the highest cancer in both men and women in terms of cause of death. So unfortunately, we haven't moved the needle all that much in terms of death rates from most of the major malignancies, but what we are finding is that we're catching them earlier when they're more treatable. So let's talk a little bit first about prostate cancer. So the prostate, for those of you who don't know exactly what this gland is, kind of like the appendix. What does this thing do, right? So the prostate is a walnut-shaped and sized organ at the base of the bladder through which the urine flows in a man, and it makes semen, fluid that goes into the ejaculation to help support the life of the sperm. And after your reproductive years, it just causes problems and keeps urologists in business, either by enlarging and causing urinary symptoms, difficulty urinating, or many times turning malignant. So the prostate is buried deep in the pelvis. There's no way you would know it's there. We can feel it on a rectal examination, and we can also do blood tests to see whether there's any possibility of it turning malignant. So that's where the prostate is and what the function is. You'll see it's just in front of the rectum, behind the pubic bone, and right under the bladder, and the urethra, which carries the urine, goes through the prostate. So some data, an update on prostate cancer facts and figures. 2019 isn't over yet, so we don't have the data quite yet. But you can see estimated new cases are actually rising. And that may be because we're detecting cancer earlier and we have more widespread testing programs out there. Estimated deaths, unfortunately, are also going up between 2017 and 2018, so close to 30,000 deaths. Or, to put it in context, a man will be diagnosed every 3.2 minutes, and a man will die from prostate cancer every 18 minutes. And this is brought by Project Zero, which is a nonprofit entity which is trying to eradicate prostate cancer through research funding and awareness efforts. So still, prostate cancer is very, very large, a very large source of morbidity and mortality in the world of oncology. So traditional prostate cancer screening, not a lot of fun for those men who have been through it. It involves the digital rectal exam, and that has nothing to do with computers. That's this digit, feeling for any abnormalities on the prostate. And then there's also the PSA, or prostate-specific antigen blood test, which is just a simple blood test that's taken from the arm vein and sent to the lab, and there are certain parameters for what a normal PSA should be. And it used to be thought that anything under 4 was fine, PSA of 4, but that's not true anymore. As we learn more about PSA, there are a lot of nuances to how to interpret PSA, rises in PSA, and even PSA according to age and ethnicity. So there are a lot of things we've learned about PSA that change how we interpret the number, the result. So I'll talk a little bit about that now. So as you can see, when we feel the prostate, we really only feel about 40% of the surface of the prostate through a digital rectal exam. And as I mentioned, it's something that we try to do quickly and as painlessly as possible. And in fact, I'll tell you, I had one patient that I said, a patient came in and I said, well, you know, when's the last time you had your prostate examined? He was about 60 years old. He said, I've never had it examined. And then I examined him and said, you know, your prostate is terrible. It's almost the worst prostate I've ever felt. He said, well, I'd like a second opinion. So I used 2 fingers. So that was not what he was expecting, but it is not a comfortable exam. And a lot of men will stay away from the urologist, and a lot of them will not really are not really looking forward to their primary care doctors doing this. And a lot of primary care doctors actually don't do this anymore. So it is a little bit controversial about whether this needs to be done anymore, especially in the advent of PSA. And there's actually controversy about whether we should routinely do PSA. because it's been heavily criticized as finding too many false negatives, false positives, and that it's not very specific for prostate cancer. So all these tools that we have pluses and minuses, and so we've invented better tools to really hone down on who has prostate cancer and which prostate cancers are important to diagnose early. So this may be a little hard for you guys to tell, but what this says is that elevated PSA does not mean there is prostate cancer. So what it says at the top, each one of these little dots represents a man. Out of 1,000 PSA tests, about 170 will be high, and out of those 170 high PSA tests, only about 41 will be from cancer. So you say, well, that's not a very good screening test, is it? And that's true. It's not a very good mass screening test for prostate cancer because about 129 of these elevated PSAs are not from cancer. They're from other conditions. So as a man gets older, his PSA will go up normally. As a man's prostate grows with age, the PSA goes up normally. If a man has inflammation of his prostate, the PSA may go up normally as the prostate grows. Or if there's infection or inflammation, that can cause a false positive elevation in PSA. So PSA rightly has been roundly criticized in the medical field as not being a good screening test for prostate cancer. So we had to come up with other tools to try to help hone down on who actually might have prostate cancer. And in fact, the US Preventive Health Services Task Force about 7 years ago said, we don't recommend this. We give these grade A through F recommendations. Well, PSA got a grade D recommendation 7 or 8 years ago and told primary care doctors, do not do the PSA. And then there was a lot of looking at this afterwards by expert panels. And it actually, the grade got upgraded back to a B. And I'll talk a little bit about what the current recommendations are. So it was really out of favor for a while to do PSAs. So, and I apologize again because there's a lot of verbiage up here. But basically, this shows 5 different expert panels: the American Cancer Society, the American College of Physicians, the American Urologic Association, which is my professional society, the National Comprehensive Cancer Network, which certifies cancer centers like Milford, and then the US Preventive Health Services Task Force. So they go from the American Cancer Society saying average risk men with a 10-year life expectancy should begin discussions about prostate cancer screening at age 50. Doesn't mean they should be screened, but start to talk about it with your physician. And then men with a PSA less than 2.5 may be retested every 2 years. So it used to be strictly a man had to have a PSA every year. That's been relaxed, as we're finding that if men are under 2.5 when they're first tested, have a very low risk of getting prostate cancer within a year, that we can go every 2 years. And men with greater than 2.5 initially should be screened annually. And then on the other end of the spectrum, the US Preventive Services Task Force says, regardless of age, men without prostate cancer symptoms should not be routinely screened for prostate cancer. Boom, blanket recommendation. Don't look for it, because if you look for it, you're going to subject a lot of men to needless anxiety if it's elevated. And even if you find that it is not elevated, there still might be prostate cancer with a normal PSA. So on both sides of the coin, it can be very inaccurate. And yeah, unfortunately, that was the case for a long time in the United States. PSA came into use in the mid-1980s, so it's been around for a while. And it was felt to be, oh, this is a miracle. We can tell whether men have prostate cancer when it first came out. But with use, through the years, we found that, unfortunately, it was not specific enough for detecting prostate cancer. So lots of panels, and there's still not agreement among what the best recommendation is for using PSA. Who should get screened for prostate cancer? So we know a couple things, right? Patients with a family history of prostate cancer. So men in the United States, just by being in the United States and being a male, you have a 1 in 6 chance during your lifetime of getting prostate cancer. If you have a first-degree relative, that is a father, a brother, or a son, your risk of cancer goes up to 1 in 4. If you have 2 first-degree relatives, your brother or your father, then your risk goes up to about 50%. So it's like flipping a coin, whether you're going to get prostate cancer if you have 2 first-degree relatives. African American men, we know, have a higher incidence. Not only do they get it younger, they also get more aggressive cases of prostate cancer. And that's clearly genetic. There have been genes identified in African American men that predispose them to having very aggressive forms of prostate cancer. So then what are the symptoms? Your question, sir. Pain when you urinate, blood in the urine, difficulty urinating. But unfortunately, when those things come about, oftentimes that's an indication that it's no longer an early prostate cancer, that it's obstructing the channel, the urethra, or causing some bleeding, and that it's probably in a later stage of development. So that's why we're looking to find these things when they're aggressive and when they occur early in men who can benefit from treatment. So it seems like a fairly complicated set of criteria. Then I'll talk a little bit about that. And then who else should be tested, right? So men who have a significant concern about developing prostate cancer. So we can't ignore men's concern about it, even though they may have no family history and they may have no symptoms. And the primary care doctor says, oh, you don't need that. I tend to test any man who wants a PSA and examine the prostate as well. And if it is elevated, we don't jump right into a biopsy like the old days. There are many other things that we do prior to recommending that a patient have a biopsy, because we were doing way too many biopsies in the old days. I don't know if anybody here has ever had a prostate biopsy. It's not exactly the most fun thing to go through, especially an office biopsy under local or no anesthesia. So what are some of the causes of a false positive PSA elevation? Why is my PSA high? I don't have prostate cancer. Well, it could be an infection, and it could be an infection that you don't even know you have. It could be inflammation of the prostate, what's known as prostatitis. An enlarged prostate, everybody's prostate grows with age, and the PSA is directly proportional to the size of the prostate. Or it could be from other things which cause direct pressure on the prostate. Bike riding, even exercise bicycles can elevate the PSA with chronic use, or other direct pressure, motorcycles, horseback riding. Men who are in the gym every day and sitting on straddling benches and lifting weights, that can also elevate your PSA, through direct pressure in a consistent basis on the prostate. So that you have to really ask a man, have you had any symptoms of infection? Do you bike? Do you work out in the gym? When you work out in the gym, do you sit on straddling type of exercises? Is there any direct pressure that you can think of that's put on the perineal area, the area between the legs, that could contribute to a rise in your PSA? So you have to interpret the test result in that context of why it might be elevated. So we used to say 0 to 4 was the normal range. But as we studied PSA and incidence of prostate cancer more and more, we found that that didn't hold true anymore. And men have normal ranges of PSA depending upon their decade of life, depending upon their ethnic group, and also the size of the prostate. But this is merely a table showing how PSA normals will vary remarkably depending upon your age and upon your ethnicity. So if you're a Caucasian male who's 65, up to 4.5 may be considered normal. However, if you're an Asian male who's age 42, if you have a PSA of 4, that's way too high. So nowadays, we will interpret the PSA according to age and according to ethnicity. And then there's one other factor, the PSA velocity. So say a man comes in and he had a PSA, he was a white male who's about 65, and he had a PSA of 2 last year, and he comes in now and it's 4. It's doubled in a year. That's still normal by this table. However, it's not normal because the velocity of the rise is statistically higher than could be accounted for by age and benign growth alone. So what I tell men is, do your PSA at the same lab all the time, because there are a few different tests out on the market, and depending which type of assay or which type of test you have, it can vary the level of the PSA. So it's important to be consistent where you have your test done, and a lot of doctors will recommend don't have a prostate exam right before you have your PSA, because that can elevate it as well. Well, when we looked at that over years and years, we found it didn't alter it all by all that much, actually. It was maybe 0.1 or 0.2. It didn't get you into the next category in terms of rise. So it's important to be consistent. And then there's unknown. We don't know why your PSA is so variable. And again, that's why these other tests have been developed to try to hone in on who might really have prostate cancer. So our goal is to detect the prostate cancer before you can feel it, before you know it's there, before it's causing any symptoms. When it's basically a group of cells within the prostate that you wouldn't otherwise know is there unless you do some form of early detection, and looking for these aggressive cancers before they spread. Because once they spread outside the prostate, they can still be treated, but they're not curable, so to speak. We have great treatments even when men come in with prostate cancer all over their bodies. I have many men that I've treated for several years. They were first diagnosed with prostate cancers, the cat's out of the bag. It's all over their bodies. But we put them on hormone treatments, and they tend to do very, very well and live a long time just on hormone treatments. So it can be treated at any stage, but it can only be cured in the early stages. So that's what we're looking for. So one of the things that I use very routinely is something called the 4K score test. And this is a blood test that's done in the urologist's office, and it's sent off to this lab. The company's called OPCO, and it's actually looking at 4 protein levels in the bloodstream, not just total PSA, but something called free PSA, which is a component of total PSA, another protein called intact PSA, and then there's another HK2, which is a kallikrein, or a molecular substance which can also be elevated in prostate cancer. And so what the lab does is they take the measurement of these 4 proteins, and through a very well-established algorithm, they'll give a score of what your risk is of having high-grade prostate cancer on a biopsy. So what you get, well, this just tells, again, what the components of the 4K score is, these 4 proteins, total PSA, free PSA, intact PSA, and human kallikrein 2. What you get when you get a report back, and this is what I'll show my patients when they come into the office, is this color scale. And this man had a score of 4%. It's a little hazy, but you can see that's in the green range. Over 7.5 is in the higher risk range, and over 20 is in the highest risk range. So this gives me an idea of what their risk is for having high-grade prostate cancer. So high-grade cancer is a grade 7 or higher prostate cancer. So we grade prostate cancer, I'm going to show that in a minute. We grade prostate cancer 2 through 10. And it's based on how the cells look under the microscope when we have a positive prostate cancer biopsy. And it's always a combination of 2 scores. So what you will typically see on a prostate biopsy is a grade 3 plus 4, meaning most of the cancer cells are grade 3. And the second most common cancer cell is a grade 4. We put that score together, and it's a 7 sum, a sum of 7. That's the Gleason score, named after a famous pathologist at the Armed Forces Institute of Pathology. That's the Gleason score, 7 out of a possible 10. That's a high-grade cancer. So what this predicts is a cancer score of 7 or above on a biopsy for prostate cancer. You say, well, I'd like to know if I have low-grade prostate cancer. Unfortunately, this test doesn't tell you anything about low-grade prostate cancer. And what you may say, well, I might have low-grade prostate cancer. And low-grade prostate cancer, as we follow it over years and years, if we find it and don't treat it, many of those men do very well without any treatment whatsoever. So grade 6 or lower. as long as it's a very low volume of cancer, we're doing active surveillance. I'll talk a little more about that. So these tests really hone in on aggressive cancers being found early and trying to narrow down those patients with elevated PSAs to say who needs to go on to further testing. So this 4K score is a very, very useful tool. And there's brochures about some of these tests on the front table you're welcome to take after the talk. Some of the other tests I'll be describing as well. There's also something called the exosome DX urine test. So who would have thought that, well, we didn't think that cancer cells or genetic markers are shed in the urine from prostate cancer. For a long time, we had the belief that prostate cancer occurs in the rim, the shell of the prostate, not the core where the urine goes through. Well, the researchers who developed this actually found genetic markers in the cells that are predictive of having high-grade prostate cancer in the urine. So that totally turned our theory on its ear in terms of how could a urine test, where you're not even seeing what's in the shell of the apple, the rind, and it just goes through the core, how could that tell anything about prostate cancer? But it does. And this test I commonly use in addition to 4K, or sometimes instead of 4K, to say whether a patient should go on to an MRI and or a prostate biopsy. So the traditional prostate biopsy was done in the doctor's office. We put this rather large and painful ultrasound probe in the rectum with a man awake. Sometimes they'd have Valium ahead of time. We'd put a needle through the probe, and we'd insert the tip of the needle into the shell, the rind of the prostate, that back part of the prostate that we could feel. Well, the problem with this is we couldn't get to here, the front of the prostate, or the middle of the prostate. So there could be cancer in any part of the prostate, but this was very limited in terms of where it could sample in the prostate. Limited by our visualization, and limited by what men could really tolerate being awake in the office. And this is kind of what it looked like. It looked like a blur. That's what an ultrasound picture of a prostate looked like. And this was a huge, when ultrasound of the prostate came about in the early 90s, we said, oh, this is a miracle. We can tell, actually, where the needle's going. We couldn't tell if there was any cancer there, but in the old days, we used to do these prostates with digital guidance. Finger next to the prostate, needle next to the finger. Sometimes a biopsy would come back normal glove. That wasn't good. But we really couldn't tell anything on ultrasound alone, because unless it's a really glaring big cancer, it's not going to show up on ultrasound. And the other problem is it's painful to do this in the office. Patients didn't like it. Ultrasound imaging wasn't good enough to show hidden cancers. We couldn't get to all of the prostate. So this is the rectal opening down here. So we could get to the edges of the prostate down here near the rectum. There's no way we could get all the way up here to the anterior, the front part of the prostate. And the patient could have a lot of problems afterwards in the office. Like they could bleed from this, and they could faint, and they didn't feel well, or they couldn't urinate. So I stopped doing these in the office because number one, it was painful. Number two, it didn't give me the information I needed to have to make a thoughtful decision about whether the patient had prostate cancer and how much prostate cancer and what we would do next. So I don't do any prostate biopsies in the office anymore. And that's really due to the advent of MRI and what we call MRI ultrasound fusion biopsies that we do in the operating room. And I'm going to talk about that a little bit. The MRI is useful, but not perfect either. And none of these things are perfect. The MRI can show the degree of suspicion of having a high-grade cancer. So here we go again. We won't find low-grade cancers, 6 or lower, but it can give us an indication of where a grade 7 or higher cancer is. The biologically important ones, the ones that have more of a tendency to go outside the prostate and spread and affect the man's life. And I'll talk a little bit about MRI. So MRI has really dramatically changed the way urologists diagnose prostate cancer now. And we're lucky enough to have state-of-the-art MRI here and also the tools to use the MRI images to do directed biopsies. Not all hospitals have that. So men generally don't want to deal with this when they're told they have a high PSA. And we're going to do a biopsy in the office. And by the way, you're going to be awake for the biopsy, and it's only going to be the 15 longest minutes of your life, and I might not get the accurate information from it. That's why the technology has progressed to have much more useful and comfortable tools to be able to diagnose prostate cancer. So you may have seen this a few months back in the Milford Good Feelings magazine. This is prostate fusion biopsy, and you can't see the wording here, but this is me using a device called the Artemist and my technician, Brian. This is something that's brought to the hospital. It's a very special machine which integrates the MRI that was done prior to the biopsy into creating a 3D model and fusing it in real time with ultrasound. As we're doing the biopsy, we can create a model for where the biopsy should be taken based on the findings of the MRI, and I'll talk a little more about that. But the hospital, this was started 3 years ago, and this has really taken off here at Milford. In fact, this is the only way that I will do a prostate biopsy now in my practice, doing it under anesthesia, in the operating room, under sedation, no pain, wake up, go home, and no pain afterwards either. So there's no incision to heal. So first, it involves a man having an MRI. The MRI is noisy. Has anybody ever had an MRI? It's noisy, it's long. We have to give a dye injection in the vein, and what that does, it would light up a suspicious area within the prostate, and this is a mapping of a suspicious area in this man's prostate that lit up with the dye. And these are very complicated studies to read, and we have 2 excellent prostate MRI radiologists here who routinely read these and give a score of how suspicious the area looks 1 through 5. So there's a lot of numbers in this. There's your PSA number, and there's a Gleason grade if we find cancer. And now we actually give a grade to what the MRI looks like. And it's easy to jumble all these numbers up, but the urologists use all these numbers together to decide what needs to be done, basically what the next step is in treatment. And sometimes it can be confusing. So this is the Artemis Fusion platform. It basically is a very fancy computer and a probe that goes in the rectum. So we're still getting those biopsies through the rectum, but with the man asleep. And this is an ultrasound machine, and the MRI is already displayed up here. And what this machine does, it fuses the 2 images and creates these beautiful models of the prostate. This looks like an egg. This is in one direction. This is the other direction. This is the pre-mapped lesion or suspicious area in the prostate. And then each one of these little lines is a biopsy that I've taken through that area. So not only can I make sure, using the Artemis device, that I've biopsied what looks suspicious, and this is a red area, so this is a high grade suspicious area, and these are yellow areas down here. These are lower, what we call PIRAD score, lower suspicious areas, but I've taken multiple biopsies through those areas, and then I can rotate this thing in 3 dimensions and look at it as I'm doing the biopsy to make sure I've sampled that area sufficiently. And not only that, I can go back after the biopsy and look what I've done and where the positive biopsy has come from. And for some men who aren't treated and are what we call active surveillance and are going to need a future biopsy, I can actually make sure that I biopsy in the exact same place going forward. So this has been a quantum leap of technology of how we actually perform prostate biopsies, all thanks to MRI and the technology that fuses the MRI to real-time ultrasound to create these 3D models. So every insurance company will cover a prostate biopsy. There's no insurance that won't cover prostate biopsy. And there's this. So here's the problematic part. Not every insurance company will cover the MRI. The good news is Medicare does. Medicare, which is the age of most of our patients who need a prostate biopsy, 65 and older, they do cover the MRI. But none of them will turn down a requested prostate biopsy, and they don't care whether you do it in the OR or the office. So why not do the best job you can do, take people to the OR where they're comfortable and you know you're getting adequate tissue samples. Only a urologist would do the procedure. your doctor can order an MRI for you, your primary care doc, but then only a urologist really does the biopsy. It interprets the images and then decides, when and where, to do the biopsies. So yes, but the straight answer is your primary care doc can refer you for an MRI, but usually it's because of an elevated PSA or something that we feel on rectal exam. So there has to be a reason to do this. Not everybody should have an MRI of the prostate. That would be way too much. So lots of insurance companies will say, have you had a biopsy in the office first? Have you had a biopsy without MRI? To which my answer to the medical directors is, why would I do that? Why would I do a biopsy in the office without MRI? Because the literature in urology has shown that the yield and the accuracy of doing an MRI-guided biopsy is so much better. And their answer is, well, that doesn't meet the criteria of the patient's insurance. We demand that before we'll pay for an MRI, you must have had a negative prostate biopsy, the traditional way. And so I've spent many hours over the last several years since MRI has been commonplace, arguing with medical directors about the need for having an MRI. So what do we do then? If they absolutely refuse, I still will not do a biopsy in my office. What I will do, however, is I will take the patient to the OR. I will use the Artemis device because the Artemis can also create a 3D image just based on ultrasound alone. And the Artemis can turn that ultrasound picture in 3 dimensions. And the Artemis can allow me to get to all the parts of the prostate with the man asleep very easily. So it's the next best thing to doing an MRI ultrasound biopsy. If they absolutely refuse to approve an MRI, and I really am suspicious of prostate cancer, then I will use the Artemis under anesthesia and sample the entire prostate. It's what we call a templated biopsy. So the computer, the Artemis, tells us, in order to completely sample the prostate based on our measurements, you need to go here, 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 here. And they will template a pattern which appropriately covers the entire prostate. And we take those biopsies. That's called a systematic Artemis-assisted biopsy, but not using MRI, unfortunately. And then when that comes back negative, and the patient's PSA continues to go up, then maybe the insurance company will cover an MRI after that. But that means putting the patient through 2 procedures. So we really fight very hard to get those MRIs approved. If you have a pacemaker, you can't. Generally, there are some MRI units that accommodate you. If you have a VP shunt in your head, which to take fluid off of the brain, you may not be able to. Prosthetic hips, which are made of certain materials, are allowable. You can have an MRI, depending what the material is. So you have to check with the MRI unit to make sure, and the patients usually have cards they carry around in their wallet or something saying what kind of hip replacement or knee replacement they've had. The reason being that when you put metal in an MRI, it becomes hot. And you don't want metal inside your body becoming hot because it can cause problems. And it's a big magnet. The MRI is a big magnet, and it excites metal and heats it up, and that can be very dangerous for patients. But orthopedics uses MRI more than anybody, and so people who have hip and knee implants oftentimes will get follow-up MRIs. But again, it's very dependent upon the material that's implanted. Sure. Any other questions about MRI and fusion biopsies? So yeah, the technology has progressed, wonderful technology. Unfortunately, not every insurance company will pay for it. And their job is to keep costs down, and we have big fights with them, unfortunately. So this is the Gleason grading system, which I mentioned. So as I mentioned, you get a score based on the most common cancer cell type and then the second most common cancer cell type. So these look like nice, uniform round cells up here, grade 1s, and down here you can barely recognize them as cells. They're so abnormal. And typically you wouldn't get a grade 1 with a grade 5. That would be very unusual. The typical is a grade 3 with a grade 4 or grade 4 with a grade 5. Usually if you get 2 different grades on a biopsy, they're adjacent to each other. So you'll get a score somewhere between 6 and 10. And the higher the score, the more aggressive the cancer is. So what are the stages? And this is different. So this was grade, right? What does it look like under the microscope? And this is the stage. How far has the cancer gone? So what we're trying to do with our technology is find the low grade stage 1 cancers where you can't see them, you can't feel them, you don't even know they're there, but the first thing to go up may have been their PSA, and then they may have had a high 4K score, and then we saw something on an MRI, and now this little tiny thing, we can target with a biopsy. We want to catch it before it's a stage 3 or a stage 4, which is spread to distant sites. Because again, in here, it's hard to cure it when it's already gone outside the prostate. This shows it going into the seminal vesicles, which are 2 little accessory sex glands. And grade 4, when it goes into the lymph nodes or the lungs or the bones, can't cure it. You can treat it, but you can't cure it. So we're really looking for aggressive cancers early on, grade stage 1 or 2. Here, actually, you can see the tumor kind of narrowing the urethra. And here, if it goes into lymph nodes or to the bones, you may feel bony pain, maybe losing weight, you may have blood in the urine. So those are symptoms, but again, when symptoms come on, it's usually with later or higher stage prostate cancer. Now, here's the other part of that, right? A lot of guys say, you know, I have to wait a long time to urinate, or I see blood in my urine, or I have to force the urine out. That doesn't mean you have prostate cancer. Those are more commonly early signs of enlargement of prostate. The blood in the urine needs to be investigated. But spotting between urination? On your underwear kind of thing? Yeah, so the good news is that's rarely a sign of something bad. Still needs to be looked into. Not typically a sign of prostate cancer, but could be a sign of either prostate infection or sometimes polyps or even bladder cancer, which is going to be the last part of my talk about bladder cancer. So anytime you see blood in the urine, either when you urinate in the toilet or you see spotting in your underwear, you should bring that to your doctor's attention. And those things need to be worked up. The majority of the time, it's not anything bad. So in fact, people who have microscopic blood on a urinalysis, and you can't see the urine, it's just under the microscope, generally those patients don't have anything bad going on, but they still need to be looked at to make sure there's not a kidney stone or a mass in the kidney or a mass in the bladder or something else. So the vast majority of patients are fine. They're benign reasons they might have blood in the urine, but they do need to be evaluated. So what are the treatment options for prostate cancer? So this talk is more about detection of prostate cancer. I'll mention the treatments because that's a whole separate topic in itself. And actually, there is a video that I did a couple years ago on the hospital website if you want to see more about treatments for prostate cancer. So there's surgery, which is complete removal of the prostate. Again, this is for early detected prostate cancer. And we have a Da Vinci robot here that we use to remove cancerous prostates through small incisions. There's external beam radiation, which is invisible x-rays, painless x-rays, which they do across the street at Dana-Farber here in Milford to kill prostate cancer, painless. Takes about 7 or 8 weeks, about 15 minutes a day, Monday through Friday. Go in the machine, x-rays focus on prostate, get up, walk away, go about your business, and really very, very effective and doesn't really interfere with your life. Again, good for certain types of cancers. We have Dr. Peter Oreo here from Dana-Farber, one of the world's experts on brachytherapy or implantation of radioactive pellets into the prostate. That's done one time in the OR. And there are other what we call focal tumor treatments, cryosurgery or freezing the prostate. HIFU is high-frequency ultrasound of the prostate, so you can actually kill cancer with ultrasound waves. It used to be ultrasound's only good for taking pictures. Now you can actually kill cancer tissue with ultrasound and high frequency. And then there's active surveillance, which we're doing more and more, where we're finding cancer and we're not watching or waiting. Remember what we used to call this watchful waiting. We're being active about doing surveillance and seeing whether the cancer is progressing. And many men, when they have low-grade, low-volume cancers, can be watched very, very carefully and tracked. And then if it seems like the cancer is progressing, then we would recommend treatment. So we're doing this more and more, and we have better and better data to show this can be very safe in men with low-grade, low-volume prostate cancer. So what are the criteria for active surveillance? Well, number one, you need a willing patient. So if a patient is not going to come back to you and doesn't want to come to frequent visits, at least 4 times a year, to check their prostate and do PSAs and possibly another MRI, they're probably not a good candidate for active surveillance because they're not going to come in for their follow-up. So what are the other criteria? Well, the patient has to be willing to do serial PSA blood tests and digital rectal examinations at a minimum. Repeat MRIs, because that's how we determine whether a small spot is getting bigger. Possibly repeating the biopsies if those areas are getting bigger or the MRI appearance is changing. And then there's another option we have talking about genetics and how we're using genetic studies to determine whether there's patients in active surveillance. And one is called Oncotype DX, and that's a genetic test where we take the tissue from the prostate biopsy and we'll send that out to an outside company to look and see if it's a grade 6 or 7, how aggressive might that grade 6 or 7 be? And is it okay to watch this grade 6 or 7, or do we have to act and treat this grade 6 or 7 cancer? So we take the tissue that's already been obtained on a biopsy, we send it to this company, and then they give us a scale, and this is the low end, the yellow end, and this is the high end, the black end, and they'll give us a number and assign a risk. So this patient, using the genetic testing, was assigned a GPS score of 12, which is in the very low risk range. And I apologize because you probably can't see the detail in the back. But this gives us 3 measurements. The risk of dying from prostate cancer is of having this be the cause of death, 1%. The risk of having metastases from prostate cancer or spread, 1%. And the risk of adverse pathology, which means if you took out the entire prostate, what's the risk that when they looked at the whole prostate, when we took it out, it was actually worse than what we thought. And in this patient, it was 14%. So this is a very, very helpful test. Doesn't require any additional work on the patient or doctor's part. We basically send the tissue results to this company, and they'll give us a risk score, and then look at these 3 measurements to help direct the patient as to what the best treatment would be. And if you're up here in the high, intermediate, or high range, that really changes the equation very significantly. So this can be done on the tissue that's already been obtained. And then there's even fancier tests. So let's say you had a negative biopsy. There's something called a confirmed DX test. And what it does is it takes the tissue that's benign, and so say your PSA is high, your 4K test is high, the MRI is suspicious, and then we do the biopsies and we go through the areas the MRI tells us to sample and other areas of the prostate. So we always do a complete sampling of the prostate when we do an MRI guided biopsy. And say all that's negative for cancer. You're saying, well, can you help me determine what is my future risk of developing prostate cancer? So we'll take the tissue that was taken at your biopsy and we'll send it to a different company called Confirmed DX. And then they'll give us a score, again, a negative or positive score, as to whether that tissue has a predisposition or a tendency to develop aggressive cancer in the future. So we're taking benign tissue, looking at the DNA in the benign tissue, and looking at certain factors. One's called methylation, which is a chemical reaction, and seeing whether it's safe to continue active monitoring, or, hey, we might have missed something here. This confirmed DX came back positive. We better repeat the biopsy and or the MRI. So more and more honing down. Remember the 1,000 men who had elevated PSAs? We're really getting very, very specific about who we're really concerned about, whether you actually had a positive biopsy or you've had a negative biopsy. We can be very exact in terms of guiding men on what the next step is. Any questions about that? And there's a lot of information, a lot of testing, and it really, but these are routine tests now in the urologic world that help really to determine who has prostate cancer and who needs to be treated. So I want to switch gears just for the last few minutes and talk about bladder cancer, because although this is not as common as prostate cancer, it affects both genders, men and women, can be life-threatening if caught in the late stages, and is easy to detect using modern methods. So out of the newly diagnosed cases of bladder cancer this year, only 1/4 will be bad, muscle invasive or into the wall of the bladder. The good news is 3/4 won't be into the wall of the bladder. They'll be on the surface of the bladder and much more easily treated and cured. The bad news is there's still about 81,000 new cases a year and 17,000 people a year who die in the United States from bladder cancer. So it is a major health condition still in the United States. And catching it early when it's in this non-invasive state is real important rather than catching it late when it's invaded the muscle wall of the bladder. And I'll show you some pictures about that. So what are some risk factors for bladder cancer? Well, the biggest one is smoking, right? Not sure about vaping because it's too early yet, but definitely smoking. Medications, some medications can contribute to the development of bladder cancer. Arsenic, chemical exposures, chronic infections, chronic urinary tract infections can lead to early bladder cancer. And then obviously, as in all cancers, there's the genetic factor, what was pre-programmed in your DNA to turn into a malignancy eventually. So there's many things that impact the incidence of bladder cancer. So what are the symptoms of bladder cancer? Well, they're similar to prostate cancer, but again, men and women can have these. Blood in the urine, pain with urination, frequent urination, and in the late stages, when the bladder cancer has gone through the wall or into other organs, you can have back or pelvic pain. So this is something we want to catch early. But the number one symptom is blood and painless blood in the urine. If you have pain and you're passing blood, or likely that's either an infection or inflammation. But if you're passing blood or clots and having no pain doing it, that really needs to be aggressively looked into in terms of, does somebody have bladder cancer? So what do? Well, we tell the patient to give us a couple urine tests. So what I'll do is when I first see a patient, I'll send them home with this little door prize, gift pack, called Cytologies and Urovision. And this has 3 cups in it. And they ask the patient to give me their first morning urine specimen for 3 days in a row. And then it gets sent to the lab, and they look for cytology, where they'll actually put the slides they'll put the cells on a slide and look for cancer cells, or something called Urovision, where they subject it to ultraviolet light, and they can actually tell abnormalities based on how the cells fluoresce under ultraviolet light. So both of these tests can be done through one kit. This is called Urovision and cytology. So this is one of our routine tools in deciding what to do next and what the risk of bladder cancer is. And then there's cystoscopy, which if anybody had a cystoscopy in the old days, they would never volunteer for another cystoscopy. We used to use rigid tubes and rods and really painful. Now we use a very slender scope that's thinner than a pencil. We use numbing medicine. Sometimes we use Valium as well. It literally takes 60 seconds in the office to look in somebody's bladder. No fasting required, no drinking stuff like a colonoscopy, none of that. Walk in, look in the bladder, walk out. And we know right away if there's anything inside the bladder to worry about, a polyp, a tumor, a stone, inflammation, etc. So this is our main tool for diagnosing bladder cancer, putting a cystoscope in. And every urologist does this in his or her office. And what we want to do is catch bladder cancer early. When it's stage 0, or just in the lining of the bladder, it's obviously much better to catch it than before it's a stage 3 through the muscular wall, or stage 4 into the fat around the bladder, because again, it can be treated in all these stages, but it's really best cured, easily cured in stage 0, 1, or 2. And it depends upon the depth of penetration into the bladder wall is how we stage it. And there's also grades of bladder cancer, just like prostate cancer. It's a lot simpler. There's not 10 grades, there's only 3 grades of bladder cancer. Again, that depends on how things look under the microscope. So here in Milford, we have acquired this blue light cystoscopy system to help us better detect hidden cancers. And if anybody has gotten this magazine last month, Good Feelings, and there was an article in here. This is my patient. She's a 90-year-old lady who travels back and forth across the country several times a year. And she was concerned about early recurrence and not being able to make her cystoscopy appointments and missing cancers. She underwent this blue light procedure, and what it consists of is a special dye that's put in the bladder before cystoscopy, and then cystoscopy in the OR using a very specialized video equipment. And what it does, it makes hidden bladder cancer show up. And so one of the problems with bladder cancer is when it's like this, what we call carcinoma in situ, it's a very superficial cancer on the surface of the bladder. Sometimes it's hard to tell that it's even there, but it can be very, very aggressive. Even though it hasn't gone into the wall, these CIS or carcinoma in situ type of cancers can be just on the surface and then very suddenly spread. So we want to catch these things very early because they don't always go in an orderly fashion like this. They don't always go A, 1, 2, 3. Sometimes there'll be carcinoma in situ and then it just spreads outside. So using blue light, we're able to visualize what might look like a normal bladder wall. After we put the dye in and use the special scope, we can see this pink area light up. And that would never have been detected without blue light. So that's something we're routinely doing now in the Milford operating room. So again, it's for patients who have first diagnosis or recurrent bladder cancer, because bladder cancer is one of those things that tends to come back a lot. And you need frequent cystoscopies to detect early recurrences. And the grade of the cancer is determined by scraping it out. So we put a fancy resectoscope in, we take the tumor, we resect it. Going ahead too fast. We resect it, we scrape it out using a hot loop, and then scar tissue forms. And when we take this tissue out, we look at it under the microscope. If it's a grade 3, aggressive type of cancer, it has a high likelihood of recurring very, very quickly. If it's a grade 1 cancer, it can still recur, but it may not recur as quickly, and it may never become one of those bad cancers. We always take the tissue for both the grade, how it looks under the microscope, and the stage, or how invasive this is. Is it just on the surface, or is it into the muscular wall? So the goal is get out all of this tumor, also take some of the muscle underneath to see whether the tumor has gotten into the muscle wall. So that's important at surgery. Make sure you got everything out and that you are able to stage the tumor. And the pathologist will say whether or not there is muscle in the specimen. But then a different spot can come up. So bladder cancer is a very sticky tumor too. So when you resect it, the cells tend to go to other places in the bladder and they implant very easily. It's a very sticky tumor and it can spread just by scraping it out, unfortunately. And so we have other treatments for that. And there's Florence, as I mentioned in the magazine. She has had at least 2 or 3 bouts of this, and we're able to find her tumor very nicely using blue light. And if it does come back quickly, we use something called BCG in the office. BCG is Bacillus calmette-guerin vaccine, which is used to prevent tuberculosis. It's used in Europe and other places throughout the world. We create a solution of this and we instill it in the bladder with a catheter. We do this in the office. And this is for people who either have high-grade cancer, bladder cancer, when we first diagnose it, or they have many recurrences of bladder cancer. We'll put this in the bladder and let it sit there for an hour. And we put it in with a little catheter, and the patient's told to hold it for an hour. They don't have to stay in the office. They can go home and then urinate it out. And we do this once a week for 6 weeks in a row. And it's about 85% effective at preventing future occurrences of bladder cancer, as long as it's a superficial kind of bladder cancer. Mitomycin is another drug that we use. It's not as effective as BCG, but can be used as a second-line therapy when BCG fails, or if BCG is not available. So because this drug has worked so well, we've had a nationwide shortage of BCG for the last 3 or 4 years. So it's becoming more and more difficult. There's only one manufacturer. There's only one, and it's been very, very difficult. And they're rationing the BCG, unbelievably. So I'll get 1 vial a week from the company now. So it has become in short supply because it's used so widespread. So mitomycin would be one of those drugs that's used in a similar fashion, has a high cure rate. BCG cannot be, so these are certain nuances about drugs in the bladder. You can't use BCG right after surgery because if BCG gets in the bloodstream, when the blood vessels are open after surgery, it can be very dangerous. So we put in mitomycin right after surgery because it's very safe to use right after surgery. Then there's a new drug called gemcitabine, which works sometimes when BCG and mitomycin don't work. So there are many, many drugs that we can put in the bladder to help prevent recurrences. But mitomycin is most commonly used one right after surgery. Now, sometimes there's no option for BCG or mitomycin or any drugs to put in the bladder, and it's muscle invasive when we find it, and that means taking out the entire bladder. And that's a big operation to take out somebody's bladder. Because in a male, we not only take out the bladder, but we take out the prostate because it's next to the bladder. And in a female, oftentimes we'll take out the bladder, but also take out the uterus and do a complete hysterectomy because the uterus and the bladder share the same wall. And if we leave behind the uterus, sometimes we'll leave behind microscopic bladder cancer as well. So a big operation. And then the urine has to come out some way. So the simplistic way is to create a stoma, or what's called an ileal conduit, a piece of small bowel is used to create an opening or an ostomy, kind of like a colostomy, but it drains urine. And then the ureters from the kidneys are plugged into this, and it's just continually draining into a bag. And this operation's been around for 50 years. It's called an ileal conduit when we have to remove the bladder. So that is still a tried and true way of curing muscle invasive bladder cancer. These days, we're doing more and more neobladder, new bladder creation. So you have a lot of spare parts within you. You didn't know this, but we can take your bowel, either your colon or your small intestine, or sometimes both, and take what is tubular and create a sphere out of it through suturing and stapling, and then plug the ureters into that, and sometimes even plug it into your urethra, if the margins are negative at the urethra, and this can act as a normal bladder after we've taken out your cancerous bladder. So it's called neobladder creation. That's even a longer operation. These operations can take 10 hours to remove your bladder and create a neobladder. Big operation, done mostly in academic centers. Also can be done with the robot as well, but work very, very well in curing bladder cancer and also restoring a normal lifestyle where you're urinating through your urethra. So this has been around for about 20 years. So the lining of the ureter and the lining of where the urine collects in the kidney is the same as the lining of the bladder. So you can have the same exact cancer in the bladder, the ureter, and in the kidney. So what happens when it's in the ureter? When it's a small amount and it tends to be low down, we can go in with a scope and instruments to burn it out if it's superficial. Unfortunately, if it's a large tumor in the ureter or it's high grade, then oftentimes you have to take out the entire kidney and ureter, and that's a bigger operation. And sometimes, if it involves your bladder, it can involve your ureter and your kidney, the collecting system of your kidney, and you take out the kidney, the ureter, and the bladder, you're left with one kidney attached to a stoma or a neobladder, and that's fortunately very rare, but the same process that goes on in the bladder, the malignant change, can go on in the ureter and kidneys. So if after you have your bladder removed for invasive bladder cancer, you have to do very careful surveillance of the remaining kidneys and ureters to make sure there's no cancer, early cancer development through CAT scans, with dye, sometimes by scoping patients and putting a ureteroscope. You can get a scope all the way up into the ureter and kidney, and you can directly look in the collecting system to see if there's any sign. FISH test is Eurovision. That's this. That's just another name. Fluorescent in situ hybridization is FISH. That's this, Eurovision. Eurovision is the brand of FISH. So that's neobladder. So in summary, just because the hour's getting a little bit late, to summarize, there are many new techniques of determining who needs a prostate biopsy, 4K score, exosome, that's a urine test. New techniques of finding prostate cancer in a biopsy, chiefly MRI and using MRI ultrasound fusion biopsy. Deciding which ones need aggressive treatment and which ones might be good for active surveillance. Genetic studies like Oncotype DX. techniques to detect bladder cancer, Urovision, and flexible cystoscopy, much more comfortable and much more easily tolerated in the office. And finding invisible bladder cancers through blue light cystoscopy, that is that pink fluorescence. And then new techniques of treating bladder cancer, BCG, other chemicals like mitomycin, and then neobladder creation for muscle invasive types of cancer to try to preserve person's quality of life and normal urinary patterns. So at that point, this is my contact information. I'm just up the road here off Asylum Street on 140. Yeah, there's some cards and material on the front desk you're welcome to have. And you know, I'm happy to chat or entertain any questions. And I want to thank you for attending this seminar. I know that there's going to be seminars coming up in the future, and you can either find them on the Milford Hospital website or in the Good Feelings magazine, the dates. And I want to thank you for your attendance. And if there are any other questions, I'd be happy to answer those. So thank you very much for attending. Thank you.